Good afternoon, everybody. My name is Jennifer, and I will be the presenter for this session, which is how to deal with medical staff questions and to convey to the provider. Before we dive into the bulk of this presentation, I thought we'd start off and introduce myself a little bit. So like I said, my name is Jennifer, and I am a nurse practitioner with Planned Parenthood of Wisconsin. I've been working for Planned Parenthood since 2015. I recently transitioned from the role of a nurse to a nurse practitioner, which is very exciting. And at Planned Parenthood, I specifically work within centralized follow-up services and the call center. So I don't necessarily see patients face-to-face or see them in the clinic, but I do a lot kind of on the back end, returning patient phone calls, calling patients about test results, doing chart audits, reviewing labs. So this presentation kind of hits home for me a little bit because it is something that I do every day. So definitely with this presentation, I hope that you get a little bit better sense of how exactly we can talk to patients and get the information we need so we can make a plan of care that's best for them, and also how to talk to your team members about a patient's concern. The target audience for this presentation will be frontline and administrative staff. And I briefly just touched on it, but really there's three objectives for this presentation. The first is to be able to triage patient medical questions appropriately to staff, become familiar with the various communication tools to collect information from patients, and learn how to effectively convey patient concerns to the provider in a succinct manner. So I was thinking, like, where do I begin with this presentation? And of course, I was brought back to, let's start with the definition here. And with this presentation, I think it kind of encompasses this whole triage process. So we're going to start with what exactly is triage. So according to the Merriam-Webster dictionary, they had two different definitions of triage. The first being the sorting and allocation of treatment to patients, especially in battle and disaster victims, according to their priorities designed to maximize the number of survivors. Commonly, I think of that movie Pearl Harbor, where after Pearl Harbor was attacked, the nurse ran out and she had her lipstick and was marking all of the men coming to the hospital and triaging them into like, are they fatal? They're not going to survive their injuries. Are they critical? So often when we think of triage, we might go to kind of battle era. The other definition is sorting of patients as in an emergency room according to the urgency of the need for care. This is another, I think, really common application of triage. So if you have two people walk into an emergency room at the same time, and one person is reporting urinary symptoms, but the other person is reporting chest pain, who needs to get seen right now? Who needs to get urgently evaluated? Who has possibly a more severe health condition and worse health outcomes if that need is not addressed? So that's kind of where this triaging idea comes into play. Within the context of sexual and reproductive health care, I was thinking about that, and I think triaging maybe has a little bit different of a form. However, it's still seeking to understand the patient's concern. You're determining if that patient needs further evaluation. Triaging helps to determine where the best place is for that patient to get that evaluation, whether it's at your organization or somewhere else. And then also determining when that evaluation should be sought. Is this an urgent concern? Can this wait to be seen later in the week? So I think triaging kind of looks a little bit differently within the context of, sexual health care, but there's still those underlying themes of understanding somebody's need, their urgency, when they need to get seen, etc. So most commonly, when I was thinking about this presentation, I would say triaging is probably going to occur over the phone, especially for that frontline and administrative healthcare staff. You are likely the ones who will be answering that phone call when the patient has questions or concerns and they need to talk to somebody. So a lot of this presentation is going to focus on kind of the phone triaging process, though you certainly can apply these principles to in-person visits as well. Phone triaging in particular, and I guess triaging in general, comes with a great deal of risk, okay? And it's really for two reasons. One, when you triage somebody, there is the potential that you underestimate their problem, okay? They may be telling you this information, you're like, oh, okay, it's not that urgent, it's not that big a deal, it's probably a cold or whatever, okay? So you could underestimate the problem. The other concern is that you could delay care resulting in harm. Oh, it sounds like you have a migraine. Why don't you come in later today? Well, what happens if this is a potential aneurysm? And this is actually not a usual headache. This is the worst headache they've ever had. That's a definite red flag. So triaging can absolutely be risky. For that reason, I want to iterate this, and I put it in red text here. It is not the responsibility of frontline and administrative staff to triage patients' phone calls or patients' concerns, okay? Because of that level of risk, that is not your job. That is left to licensed staff. So I guess the big question kind of becomes, well, what is the responsibility of frontline and administrative staff in the triaging process? And that responsibility is to gather key information and then redirect that person for further assessment and medical advice. So you are the starting point for this triaging process. You're not the end point, but you're the starting point where you're starting the process, you're initiating further follow-up, or you're talking to your healthcare team members about what needs to happen next. So again, do not provide medical advice. Do not tell a patient, oh, that's normal. Yes, that's a side effect. That's outside of your role. You are the information collectors and gatherers, and then you pass that along. So this is a repeat slide where I talked about triaging within reproductive and sexual health care. So within this context, again, your responsibility is really going to lie in understanding the patient's concern. So let's dive in more into talking about your role within triaging. So first off, there is no universal triaging process. And I think wherever you work, that process for triaging or taking in patient phone calls is going to look different for everyone, okay? And it's going to be what works best for you. So triaging process in the workflow is going to depend on your workplace resources, which staff members are available, what technology do you have. So it's really important to understand what your workplace triaging process looks like and then what your role within that process is. Because even, your role might be a little different based on where you're working. But each triage process should really be practice specific, and it is going to involve the whole healthcare team. It's not going to be just focused on one person. Everyone will have a job within this process. So again, learn your workplace protocols, particularly for managing those incoming patient phone calls, okay? So things that I'm thinking about when we think, or at least when I'm thinking about triaging and the triaging process, things that I would want to know is what information do frontline staff need to collect? So what is your responsibility? Do you literally just, whatever the patient says, you write down and that's it? Do you have to collect a little bit more information, or how much detail do you need to collect? Do you just have to collect general information? Do if the patient says, oh, I'm having a vaginal bleeding, do you just write that down and that's that? Or are you responsible to maybe collect a little bit more information and have the patient quantify how much bleeding they're having? So again, it's a difference of a patient's calling with heavy bleeding versus a patient's calling and is soaking 2 pads every hour. So figure out what exactly is the expectation is for gathering information from the patient. Also, you want to consider how are you supposed to communicate patient, questions, concerns, phone calls, whatever, to medical staff? Because again, It's going to be your nurses, your nurse practitioners, doctors, licensed staff who will be ultimately assessing that need and then making the recommendation for care. So how are you supposed to convey that information to these people? Are you writing it down on a piece of paper and then handing it off? Are you putting in an entry into the medical record about the patient communication and then sending it electronically? Are you passing the patient phone call on and transferring that phone call directly to a different extension for the provider? So what exactly is the communication method that you're using? And then lastly, I want you to think about too at your workplace, what sort of complaints does that licensed staff, the nurse or provider, need to be notified of immediately? Or what are some red flags that if a patient tells you over the phone, you're like, okay, this needs to get addressed right now, okay? And we'll talk about some of those red flags in just a little bit. So general principles of telephone inquiries and triaging. I mentioned this already, but you, frontline and administrative staff, are most likely going to be the first point of contact, the starting point for that patient's interactions with your healthcare agency. All right, you're it. You're the first impression, okay? Your interaction with that person is absolutely going to set the tone for the rest of the phone call, for the rest of the visit, whatever it is, okay? You are starting to create that relationship between your organization and the patient. So there is a kind of a great level of responsibility that you guys carry, okay? So with that being said, there are absolutely some key expectations for frontline staff, particularly for answering phone calls. And I saw there was another presentation at this conference regarding customer service. And this is kind of going to dip into that a little bit, but this is also so very important for triaging, particularly over the phone. First off, you want to answer the phone as quickly as possible. Okay, and I know that it's going to be really difficult at times when your clinic is going, just havoc is being had. All right. It's going to be difficult, especially if you have a line of people in front of you and now your phone's ringing. It's going to be a lot to manage, but you do want to answer the phone as quickly as possible. And the other thing that I think of too is do not, and I can't repeat this enough, do not answer the phone and put the patient on hold without figuring out why they are calling first. This happens to me a lot. Unfortunately, I've had it, where I'm the customer and they, somebody answers the phone and may I put you on hold? And you're like, oh, okay. Might happen at my work. It's frustrating because, you want to be able to speak first. Okay. You want to be able to talk to that person, tell them what's going on. But they're not giving you that opportunity. They're putting you on hold right away. In the context of triage, if you answer the phone and put that person on hold right away without figuring out why they're calling, you absolutely could miss a medical emergency. Okay. I like my examples and my anecdotes. And my story about this was back in high school. I was in a car accident and I had to call my mom to come pick me up. And I was very shaken. I was totally stressed after this accident. And I called my mom and she was working in an OBGYN office. And I called the office. The front desk woman answered and she said, I'm going to put you on hold in one brief moment without figuring out who I was or why I was calling. And again, I was just in a car accident. I was frazzled. I yelled at her and I said, no, you are not putting me on hold. I need to speak to my mother. And then she knew oh, this is serious. This isn't a normal call. Again, it's not a medical emergency, but I needed to speak to somebody, particularly my mom. I needed to speak to her right now. This was not going to wait. Do not put me on hold. So if you have somebody who might be in the middle of a heart attack and they're calling you and you're like, oh, I'm going to put you on hold one moment, you're delaying care. That is absolutely a problem. So please, please, please never put somebody on hold without figuring out why they are calling you first. Okay. The other thing to do that I think is really important is that you should be providing the patient with some sort of time frame of when they can expect a call back if you're not able to directly connect them with the nurse or the provider right away. I think it's good customer care. I think it gives the patient a mindset of when they can expect that call back so they have an idea. And it also kind of has your organization have some accountability that you make sure that you're reaching out to patients in a timely manner. And again, lastly, please do not provide medical advice. I've said that multiple times. It's just that is not your responsibility. So starting the triaging process. And again, this is within the context most commonly I think this is going to happen is with incoming patient phone calls. So your phone is ringing, you're going to answer the phone, great starting point. And I know this seems kind of silly or like, well, duh, customer service, like, yeah, this is what you should be doing. But it doesn't always happen. You should always answer the phone and say who you are, what your title is, and where you're working. And I just think it's so important because, again, that's going to set the conversation up so that that person, that patient on the other end of the phone knows exactly who they're talking to. So when I answer the phone at work, hello, thanks for calling Planned Parenthood. This is Jen, the nurse practitioner. How can I help you? Easy enough, okay? Please don't ever just answer the phone saying, Planned Parenthood. Ooh, does that make me angry when I have coworkers do that? Even though if they know it's an internal call, it's not best practice, okay? The other thing to do at the beginning of the phone call is you want to collect the patient's name, the date of birth, and the best number to call them back at. Why are you doing this early? Just in case you do get disconnected during that phone call, you have a way to call them back. Lastly, the other thing to think about too is you want to confirm whether that person calling is a current patient at your workplace. Because in an ideal world, you shouldn't be providing medical advice to non-patients. And there's a little bit of risk there. If you're telling somebody or you're recommending a certain care plan, and then there's no chart for you to document it, okay? So again, examples. Once I had a patient, she was not a patient at Planned Parenthood. She had never been seen by us, but I got the phone call. She was calling. She had an abortion out of state. I forget which state it was, like a couple weeks ago. And she was calling us. She lived in Wisconsin, but she had her abortion elsewhere. She was calling us because she had questions about like probably bleeding or something after the abortion. And she just wanted to talk to somebody about it. Do I talk to patients about bleeding after abortion? Yes, I do that all the time. However, this was not a Planned Parenthood of Wisconsin patient. We had not provided the abortion. I didn't have a medical record for her. I couldn't do a chart review. So with that case, I feel for her and I apologize, but I am not the person to answer those questions for you. Ideally, you want to contact the organization that provided that service to you. So in that case, I helped her out, did a quick Google search, figure out what number she does need to call to get hooked up with the right person. Okay. Now at the same time, now I'm going to contradict myself a little bit here. I took another patient phone call. This was a gentleman who was not a Planned Parenthood patient. He was calling us because he reported that he had a new sexual partner last night. And after sex, that partner told him that they were HIV positive. So he was calling very much distressed, very upset that he was a potential HIV exposure. And he was calling to figure out, what he should do. He read about PEP or post-exposure prophylaxis. Is that something that Planned Parenthood could provide to him? So he was just trying to get some information. With this person, absolutely, I can't provide you medical advice, but I can definitely direct you and try to get you connected with the resources. So with him, I told him, unfortunately, PEP isn't a service that Planned Parenthood is offering at this time, but here's the information or here's the phone number of who you can contact in your area to get started on this prescription. And here's a website where you can learn more information about PEP. So with these phone calls, I never want to leave a person hanging. I want to make sure that they can If I can't help them, I can at least connect them to somebody who can. So once we've established, we've answered the phone, we've introduced ourselves, we got the patient's information. The other thing I wanted to think about is determining the reason for the phone call. And every patient is different, as I'm sure we all know, and everyone communicates their concerns differently. I'm sure we've all had that, some patients who are very open and very willing to share information. And then you have some patients where it's like pulling teeth, where you're like, I don't know why you're here. What's going on? Let me help you. So everyone can be different in how they share. But I think a really good starting point for the triaging process is starting with a very easy question. How can I help you today? Or what concerns do you have? That's a really good starting point. Even if I get a phone call transferred to me and they're like, oh, this person has questions about their medication, I would never start by saying, oh, I hear you have like questions about your medication. What is it? Because oftentimes patients may be calling for a completely different reason. And maybe they just didn't feel comfortable telling that first person why they were calling. So I always let the patient explain to me why they're calling, okay? Sometimes you may have patients who kind of just go off and they just start talking about a whole bunch of things and a whole list of concerns, or get sidetracked and side stories. So if you're having problems identifying like what's the concern, what's the main concern here, it is very much appropriate to ask, what is one thing or symptom that made you call for advice right now? And just help the patient kind of narrow down that primary, that chief concern. So that leads us into our next section here, the art of asking questions. And what did you know? It absolutely is an art form. So how you ask a question absolutely matters, okay? Questions can facilitate a conversation. It can help you better understand a patient's concern, their experiences, what's happening. So these questions and how you ask questions is going to direct the rest of your conversation. There are really a couple different types of questions. That would be open-ended questions and closed-ended questions, and I'll go into detail about each one in the next slides. And again, each question, whether open-ended or closed-ended, plays a role in how you collect information from the patient. So we'll start with the open-ended question. So an open-ended question, when you ask it, somebody answers it in sentences, lists, or stories. This is not a question that can be asked yes or no. So like it'd be me asking, what's your favorite color? Okay, can't answer in the yes or no, all right? But this type of question is really helpful because it allows patients to discuss their concerns freely. They can use their own words to describe what they're experiencing, and it gives a little bit deeper meaning and context into the patient's situation, okay? An open-ended question is really non-directive. The patient kind of can answer it in however they see fit or whatever they're comfortable with. And with an open-ended question, somebody might be more willing to share what's going on. Typically, these questions begin with what, why, or how. And I have that asterisk next to the why. And here's why. I want you all to be extremely careful when asking questions that start with why, okay? The reason for this, questions that start with why, are often questions that make a person feel very defensive, okay? Usually, if you ask like, well, why didn't you do this? There's a kind of a level of judgment there. It's the difference between asking, why did you not follow up, versus what caused you to miss your follow-up. So I think if you think of those questions, your response is going to be totally different based on how you ask that question. Why did you not follow up? I was busy. What caused you to miss your follow-up? Oh, well, this is what was happening. Okay? Two very different things. I really don't think there's any scenario where you should be asking a why question. And it can be difficult. I definitely need to catch myself and like, no, don't ask that question. You need to rephrase it. Next, we have the closed-ended question. So this type of question is answered with a very limited response. Usually yes or no, single or very few words are used to answer. This type of question can absolutely have its place when you're collecting information. It may be helpful if you're trying to narrow down like specific details from the patient. It's generally not ideal to start a conversation by asking a patient a closed-ended question, just because you're not going to get much of a response. So typically, this type of question is going to begin with is, are, do, did, was, were, have, has, to give you an idea. So let's go through some examples here. And so on the one side of the slide, I have a closed-ended question. And then on the other side, I reformatted that question into an open-ended question. And I think this will help give you an idea of, again, how very differently the response to these type of questions is going to be based on how you ask it. So the example would be, are you feeling well today? Versus, how are you feeling today? So with one, I could easily say, are you feeling well today? No, I'm not feeling well. Versus, how are you feeling today? Oh, I'm not feeling very well. I've had this really bad headache and, blah, blah, blah. Okay, so two very different things. One's going to facilitate a conversation. One's kind of going to stop it in its tracks. Next example, did you take your medication? Versus, how have you been taking your medication? Okay. Do you have any questions? Versus, what questions do you have? Are you having pain? Tell me more about your pain. Okay, so when you're asking questions with patients or even coworkers, start thinking about how you're framing that question, because how you frame it may change the response. I wanted to talk about this. This is the leading question. And I want you all to be extremely cautious of this type of question. And what it does, it forms the question and kind of directs the person to answer it in the perceived desired manner, okay? And we'll go through examples to kind of help solidify that. The leading question is absolutely not useful in any clinical situation, or I would say just any situation in general, and you should absolutely avoid this type of question. So some examples would be, you take your medication every day, don't you? Okay, that don't you is really implying, like, if you don't tell me you're taking your medication every day, you're probably doing it wrong. That's not great. That's not how you're going to have a great or like a good conversation with someone. You use condoms when you have sex, right? Again, you're kind of implying like you should be using condoms in how you ask that question. This next example, I would also argue is a leading question of, do you use condoms when you have sex? And I definitely have caught myself where I ask patients this question, because particularly in like my setting, being a sexual and reproductive health care provider, patients are coming to me for STD screening. They're pretty well knowledgeable of how to prevent STDs. And I would argue pretty universally known that condoms reduce your risk of STDs. So me asking, do you use condoms when you have sex? The perceived answer that would be best would be, oh, yes, I do, even if that person doesn't. I think another example would be, oh, you go to your primary care provider and they ask, do you exercise? Well, you know everyone should get exercise, so you're going to probably want to answer yes, even though that may not be what's actually happening, okay? So instead of asking the question, do you use condoms when you have sex, I think a much better question would be, how often do you use condoms when you have sex? Because then that person doesn't have to answer yes or no. They can tailor their own response to what their experiences are, okay? The last example is, you're on birth control, right? Or even you're using birth control, you don't know if that patient's taking pregnancy or not. So a much better question to ask, are you planning on becoming pregnant? Yes, no, okay, well, let's talk about that. And then we can, formulate a future plan from there. So again, with this slide, don't ask the leading question. So think when we're talking about questions and getting information from the patient, again, you want to understand your workplace or your organization's expectations about how much information you should collect on a patient's concern. Okay? Are you just quick jotting down the general concern? Or are you supposed to collect a little bit more information? What exactly does that process look like? Okay? Again, as a review, when you first talk to the patient, it is best to start with that open-ended question, kind of let the patient just use their own words, describe what's happening. You're getting a general idea, and then you can transition to closed-ended questions if you need to get more details. And again, it is not your job to take this information and formulate a plan of care. That is up to the licensed staff to do. I wanted to include this slide in here because no matter where you work in healthcare, you will always have somebody with pain, and you're going to have to collect information or assess that. So on this slide, I included two tools if you need to collect information about a person's pain. On the left, we have the pain severity scale, which I'm sure we are all very much familiar with, which is, and how I usually frame this to patients is, if 0 is no pain and 10 is the worst pain you've ever had, what is your pain like right now if you had to give it a number? Okay, so there's that way to quantify pain. The other tool that's very helpful when you need to gather information about pain is this mnemonic old cart. Okay, so with old cart, it stands for onset, location, duration, characteristics, aggravating, alleviating factors, and treatment. Okay, so with this, you would be asking questions such as, well, when did your pain start? Does it happen all the time, or does it come and go? Where is your pain? How would you describe the pain? Have you ever had this type of pain before? What makes your pain feel better? What makes it feel worse? What have you tried at home to help relieve the pain? Okay, so those are really good questions that will help you figure out exactly and understand that pain a little bit better. All right, next section will be understanding the urgency of a problem. So when you're talking to patients or when you're gathering information, in the back of your mind, I want you all to start thinking of how urgent is this concern, particularly over the phone. Like if you have a patient in the health center or at wherever you work, and they're there and they're going to see a provider, you know they're going to be seen right away, okay? If this is a phone call, you should be thinking, is this somebody who needs to be seen today? Is this somebody who could be seen later this week? Or is this someone who needs to get seen like right now at an ER? Okay, so start thinking, how urgent is this person's concern? Okay, so really that can be broken up into 3 levels. The first would be emergent. So this type of concern, you have the red flags. You're like, oh dear, okay, I need to talk to a nurse, I need to get a doctor, whoever, I need to talk to somebody right now about this concern, okay? Also, this might be you calling, or you're gonna tell a patient, you need to go to an ER right now. Can I call 911 for you? Okay, so this is somebody, they need to get seen now. A level down from that would be urgent. So this is somebody who maybe just needs a call back within 30 minutes or within an hour. Okay, so it's not something that can wait to the end of the day. It's not something that needs to get seen or like be somebody who needs to be talked to right now. It's more urgent. Okay, the last or lowest level we'll say is normal. So this is somebody who's calling and they can get a call back within the day. Okay, or maybe this is somebody who's maybe can get an appointment within the near future. So some examples. An example of an emergent situation would be somebody calling you saying, I'm having shortness of breath and chest pain. That is absolutely an ER referral, okay? That is, I mean, unless you're working in an urgent care or an ER, that you shouldn't be seeing that patient. Also, or an example of an urgent level would be somebody calling who maybe is having heavy bleeding after an abortion. So that is something I want to talk to pretty soon, I don't want to wait till the end of the day to call that person back. And then lastly, the normal level, this would be somebody who may be calling saying, hey, I had an IUD inserted a month ago and I've been having some irregular bleeding or spotting going on. That's somebody who can get a call back that day. Some red flags here in 911 symptoms, and I think for the most part this is relatively straightforward, especially if you've ever taken a CPR class. Like think about that. Think about your cardiovascular. Think about your respiratory system. If your cardio or respiratory system is compromised, that is an automatic 911 phone call or transfer. Okay, that's not somebody you need to be seeing. So again, here's just a list of things that anytime a patient would be telling me any of this, red flag, definitely, where I'm thinking, okay, you need immediate evaluation. I put an asterisk next to a heavy vaginal bleeding, a testicular pain, just because with those, depending on the situation, it might be an emergent situation where that person needs to go to an ER, or it could be more urgent where that may be something that you could see at your health center. So there's a little bit of gray area with some of these symptoms, which only makes things that much more confusing. So let's go through some more examples. And for this slide, I was thinking, like, what are some things that I would commonly get for phone calls or common patient concerns that I get, and breaking them into the different levels of urgency. So things that could get a call back within the next business day. If somebody's calling to refill a prescription, directions for how to use their medication or side effects of their medication, they were calling about their test result, or they have questions about an upcoming appointment. Those are all things that I can get to within the day. More urgent phone calls would be if I have somebody calling who is reporting continued UTI or PID symptoms, even though they've gotten treatment already, or maybe they're having new onset symptoms that I'm like, oh, this might be a pelvic inflammatory disease. Yeah, let's get you seen today or tomorrow, okay? Another urgent thing would be post-abortion bleeding, pain or fever. Those things need to get assessed a little bit more urgently. And lastly, pain or bleeding with pregnancy. That also needs to get assessed urgently. You know, you want to rule out miscarriage, ectopic pregnancy, things like that. Emergent situations. So anytime I have a patient calling with difficulty breathing, they're having chest pain. I put here the thunderclap headache, or I guess this is pretty specific. A thunderclap headache is a specific type of headache related to brain bleeds, where it's a headache that comes out of nowhere and it hits you extremely hard, like you are down and out for the count. It's a rare type of headache, but I think a more common thing is if I have patients calling with headaches, is this the worst headache you have ever had? Because if the answer is yes, that very well could be a 911 referral to make sure that they are not having, you know, aneurysm, stroke, brain bleed, whatever. I also put on here any ectopic pregnancy signs or symptoms, given that we are a reproductive and sexual health care provider. So yeah, if I have a patient calling and saying like, hey, I'm 8 weeks pregnant and I have just the sharpest pain like on my side, it came out of nowhere, it's like radiating to my shoulder, I just don't feel good, that needs to get assessed urgently to make sure it is not an ectopic pregnancy. Absolutely. Okay. The other list there is just some more signs and symptoms with ectopic pregnancy, but it's something to certainly be thinking about, especially if you haven't confirmed that the pregnancy is in the uterus via ultrasound or imaging. So kind of wrapping up this urgency section is if you're ever taking a patient phone call and you're in doubt, you're like, man, I don't know, like, does this person need to call back right away? Can they wait? I'm not sure. Just ask. I would never be upset if any of my coworkers ask me like, hey, what do you think about this? I'd rather we have a conversation and let's talk about it, and then we can figure it out together. If you're ever in doubt too, it's probably best to just overestimate the urgency level, because you don't want to miss identifying an emergent situation, okay? Or again, talk to your coworkers and see what they think. Oh, and yeah, that's my last point too, is just talking to the other members of your healthcare team is particularly if you want to, after this presentation, talk about like, hey, what are some urgent things that you were like, oh, if a patient calls me about this, I want to talk to them right away. Or what are some things where you're like, nope, just go to an ER. So the next section here is going to be about how to convey information. How do you take the information you gather from the patient and tell somebody else it, okay? So it is the matter of like, now you got the information, what are you going to do now, okay? The next step is telling and communicating that information onto the next person. But what's the best way to do that? And don't worry, there is a handy tool we're going to talk about. And that handy tool is called SBAR. And maybe some of you are familiar with it. But this is absolutely a great communication tool. It was developed by IHI, and it's a technique to provide a framework for how you should be communicating to other members of the healthcare team. Honestly, I use this framework even when I'm like calling. I just like called about car insurance, and I use the SBAR format. So this has wide applications for use, not just healthcare, okay? So with this tool, another mnemonic that stands for situation, background, assessment, and recommendation, okay? So let's kind of break apart that a little bit more. So situation, that's a concise statement of the problem, okay? So what's the problem? Why are we having this conversation? Ooh, I used a why question there. Did you see that? The next thing, background. So this is where you're going to provide the pertinent and brief information related to the situation. That's kind of where you gathered the information from the patient. The next team member, in terms of the triaging process, the nurse practitioner, the doctor, is going to be doing the analysis and the considerations for the information provided, and then they will be making that recommendation for the future plan of care. So within SBAR, frontline administrative staff are really going to focus on the beginning piece, the situation and the background. Here's just some more information about SBAR. We've already talked about it. Again, this is such a great tool. It provides a nice focused way to set expectations for what will be communicated. So no matter who you're communicating to, no matter what that healthcare team member is, you're going to give the information the same way every time, okay? So I got this from the IHA website, and I saw this example. I was like, wow, this is a really good application of SBAR, particularly within this presentation. So this is an SBAR report to a primary care physician. So maybe you have the situation, this is how you would tell a provider. You'd be like, hi, I had this patient who arrived for their appointment on the wrong day. So the concise statement, what's the problem? Patient arrived for their appointment on the wrong day. Here's the details. The patient arrived for their appointment today at 11 o'clock. Their appointment was actually scheduled for 11 o'clock tomorrow. The patient drove 40 miles and had a friend drive them. The doctor does have one appointment available on the schedule, and the other doctor in the office does have some open times. We're not sure if the mistake happened with the patient scheduling the appointment or maybe with a call center. So the assessment will be, we should see the patient today, and I recommend that we use the one available time slot we have for your hall partners to see this patient. So in this situation, you may be the one doing the assessment and the recommendation, okay? But I think this is, again, a really great tool to frame that conversation between two people. I'm really into examples, like I said. So here's a couple more examples. And these examples are a little bit more specific to things that I would commonly see at work. So maybe the situation, I have a patient calling the clinic and she has concerns of vaginal bleeding. The patient was seen at the clinic with a high sensitivity pregnancy test. Her last period was 8 weeks ago. Her bleeding started yesterday and it's getting worse. She is soaking through a pad every 2 hours. She's passing stringy clots, and she's also having some period-like cramping. The assessment for that, again, this is maybe my turn to take over. I would think about, is this an early pregnancy complication, ectopic pregnancy, miscarriage? I would recommend that the patient return to the center within the next day or two to be seen, okay? So there's one example. The next example would be, this patient is calling the clinic and has concerns of continued burning with urination. This patient was seen at the clinic 6 days ago and was treated for NGU with azithromycin, 1 gram. He took the antibiotic as prescribed and denies any intercourse since starting the antibiotic. He is still complaining of burning with urination. We don't know what his gonorrhea and chlamydia test results are because they're not back yet. Okay. For me, if I get presented this, I would be like, okay, well, we should think about other STDs to test him for. And I recommend that this patient come back to the clinic to be evaluated. Okay, easy enough. Again, this tool is absolutely applicable to many, many situations. Okay, if you're ever interested, this is the website to get this template for the SBAR communication tool. So certainly if you want to print this off and keep this and fill it out, you absolutely could do that. I definitely did that until I got more comfortable with this tool. But that's, I think, certainly an option for you. So we got that in place. So let's put everything together. So these are the takeaway points that I would, at the end of this presentation, really want you to remember. So you always want to start by asking, how can I help you today? Okay. You want to use those open-ended questions to get a general sense of the patient's concerns. You can transition to those closed-ended questions to get more details. You're thinking about how urgent that concern is and how quickly that patient needs to hear from a licensed staff member. You learned how to communicate patients' concerns with other members of the healthcare team using the SBAR format. And if at any point in this triaging process or when you're talking to patients, if you are unsure, just ask, and then you can talk about it more as a team. I put the resources here for the presentation. Certainly feel free to look at them. I know we're living in a COVID world and live Q&A isn't going to happen, but certainly feel free to email me with any questions or concerns that you may have. And lastly, what questions do you have? And you can see here, we're using an open-ended question versus asking if you have any questions. What questions do you have to facilitate that conversation a little bit better? And again, please feel free to reach out to me if you do have any questions at all. I want to thank you all for taking the time and listening to this presentation. I really do appreciate it. And as a parting gift, I suppose, I included a picture here of my adorable dogs. These are absolutely COVID rescue dogs. This is Lady on the left and Thor on the right. We just got them this year, and they're absolutely such joys, and they always bring a smile to my face, so I hope they bring a smile to yours. Thank you again so much, everyone, and have a great day.